Medicare Part B demonstration project for prescription drugs has received a lot of pushback. And we discussed a moment ago some of the reasons why there's that pushback. I'd like you each, from your perspective, to discuss the model and why you think physicians are opposing it, and are they right or they wrong? So start with you.
I'll love to provide kind of the physician input I've had, and then Rena, would love to hear your description of the model. But basically, changing the way oncologists are paid for administration of Part B medications, changing it from ASP plus 6.5 to 4.3 after sequestration to 2.5 with a $16.80 fixed fee. We've discussed how community oncology has dwindled from 90% to 50% of where oncology is delivered. And so there is, I was at a COA conference yesterday, there's concern among community oncologists that this type of policy could continue that trend in making community oncology less financially viable. And the second piece that I've heard is there's a feeling that this is somewhat of an experiment in terms of it depends which zip code you're in terms of how you're going to be paid without an opt-out. So those are some things that we've heard, but I'd love Rena's economic analysis.
Sure. So basically the demo fundamentally changes how physicians get paid for using infusion drugs. There is data that suggests that the margin between what practices purchase these drugs from providers or from pharma and what they get paid is significant and floats approximately 50% or more of practice expenses in a given year. So essentially what the demo is doing is trying to break practices' revenue being predicated on the high prices of these drugs and using both high-priced drugs but also combinations of high-priced drugs. So there are two parts of the demo. The first is just simply reducing the amount of money that reimbursement is paid for a given drug to being something close to average or closer to average sales price. This is going to reduce the spread or the margin that practices keep. And then that loss is going to be made up with a flat payment that's going to try to offset some of the administration costs of purchasing the drug, storing the drug, et cetera. In phase 2, CMS is going to experiment with a number of alternative payment methods. The payment methods have two components, one for patients, one for providers. On the patient side, patients will see very large reductions in their out-of-pocket costs that are required for being treated for these drugs. Currently under fee-for-service Medicare, people pay 20% co-payments on the cost of those drugs, with the 80% being paid for by Medicare. What Medicare is proposing is that 20% will dwindle to zero or close to it. On the provider side, there's going to be experiments on how exactly physicians are going to be paid. Some of it will be the establishment of a pathway type program. Others will be performance-based incentives for using certain types of treatments and then hitting certain types of outcomes. We'll kind of see what they look like as they roll out. I do believe that not all practices are completely opposed to the Part B demo, but the Part B demo does really change how practices make money, particularly community-based practices.
The goal here is to decrease the expenditure on drugs. That's what the goal is. And if that's the goal, and
I disagree.
Okay. Well, let me just finish my point. And if the goal is to decrease expenditures on drugs, and the way we're going to do that is to take away the incentive of using more expensive drugs, because that's how it's designed. In fact, I think that's how it's even talked about. And the idea is that we're going to keep the physician whole by giving them a fee for the infusion. The thing that just doesn't pass the smell test is the $16, because it's a lot more than $16. And when you think about it, if you're a practice of 3 to 5 doctors and you have to cover the full cost of an oncology nurse and a chair and the cost of inventory and the opportunity cost, and you add all that up, everybody knows it's more than $16. And I think where these things sort of fall apart is, and where it engenders, actually even from doctors, resentment, is you want me to buy the drug for $4,000. I now have to make sure I sell that drug, otherwise I lose $4,000. This is a lot less than going up the block to the hospital where I don't have to buy that drug.
Right.
And the reward for me taking this risk, doing the right thing, again, paraphrasing, is $16.
Well, that's not how it works, right? Because you're paid at average sales price, that $4,000 plus whatever it is, the average sales
Well, that's
price.
just nets out.
Right, so that nets out as
But
zero.
that
So you're
assumes-
made whole for that.
But that
and then the
assumes you have
question is,
100% efficiency, which never happens in any system.
I don't believe the Part B demo is about reducing costs. What I think the Part B demo is really about is breaking the unholy alliance between pharmaceutical manufacturers and physician practices in keeping drug prices high and exploiting this system where reimbursement does not reflect the actual sales price or the actual acquisition costs of these drugs. That margin that physician practices make is off of the difference between the acquisition price and the reimbursement price is significant. It's been significant for years. And practices, as you mentioned, but others have as well, base a lot of their practice on making sure that they maintain that margin. What the Part B demo is doing is essentially breaking that as a model of financing oncology, and in saying instead, we are going to move towards a system where you get paid for what you do based on the outcomes of patients, and it's not going to matter whether you make more margin on one type of treatment versus another. We want you to do the best thing for the patient.